My name's Claire Davies. I'm a clinical therapy manager from Braun Medical, and I'm also a paediatric nurse. I'm going to take the next few moments of your time to set the scene about the underdelivery of IV antibiotics and how this occurs, highlighting the importance that every drop counts. So how does the underdelivery of IV antibiotics occur? Of all intermittent infusions that we deliver in UK nursing, whether they be via infusion pump or via gravity, 60% of these infusions contain antibiotics. And I'm going to tell you that often up to 40% of that patient's dose never actually reaches them. So how is this the case? So it's very common in adult nursing practice that when an infusion finishes, we disconnect the infusion set and we discard it. And if I can just draw your attention to the animation on the left side of the screen, when the infusion ends, this infusion set we discard always has a proportion of the drug left in it. And when we discard this set, the proportion of drug we lose is dependent on the size of the initial drug bag that we're infusing our antibiotic from. So if your antibiotic is in a 100 ml bag, you could throw away up to 20% of the patient's dose. And if it's a 50 ml bag, that could be up to 40% of that prescribed dose. So this isn't just about waste, it's about that unintentional underdelivery of the antibiotic, where potentially the patients may only be receiving 60% of their therapy. The absence of infusion line flushing didn't always used to be the case in UK adult nursing. We used to piggyback our drug bags onto a primary line. If you watch this animation, what used to happen is when the antibiotic bag ran dry, the patient's maintenance fluid would automatically follow, therefore flushing the remainder of the dose into them and delivering the full dose. This is now no longer common practice in UK adult nursing. There are some exceptions, however. Haematology and oncology units routinely flush their intermittent infusion sets in order to deliver the full dose. They also use line flushing as a method to facilitate the use of a single set for multiple infusions of either the same drug or different drugs. Pediatrics and neonatology, I'm a children's nurse, we routinely flush our administration sets. And it wasn't until I began working for Braun Medical in adult nursing that I realised that flushing wasn't routine practice across all clinical areas. And it's actually up to us as clinicians to ensure we work together to ensure patients all receive the same standards of care. What is the impact of this underdelivery of IV antibiotics? Data shows that up to 9 oil tankers of IV antibiotics that should have been infused into patients are discarded each year. Now, these antibiotics could find themselves in the water system or in landfill and could be potentially contributing to our global antimicrobial resistance crisis. So what guidance is there for us as clinicians to ensure we embed routine IV line flushing into our routine nursing practice? In 2021, the National Infusion and Vascular Access Society published their line flushing guidance. And in doing this, they offer us 2 methods by which we can achieve this. Method 1 involves unspiking the empty drug bag and respiking the administration set into a flush container, therefore allowing the flush to follow the drug through and infuse the total dose into the patient. There are 2 considerations if you select to use this method. The first one being it's important that you select an administration set with an air stop filter in it to prevent air entering the system, because if air enters the system, you of course can't follow with your flush. And secondly, just show slight caution in the risk of fluid overload in your patients. Method 2 involves selecting an IV administration set also with an air stop filter, but this also has a needle-free access above the drip chamber. So this time, when the drug bag empties and the drip chamber empties, the fluid level will stop just below the drip chamber, allowing us as clinicians to add a small volume flush with a syringe to the drip chamber. That flush will then follow the drug and flush the remainder of the drug into the patient. And that delivers it at the same rate as the original drug infusion and delivering the full dose. Following the NEVAS publication in 2021, several other influential bodies followed suit. We now have the All Wales Guidance on Flushing IV Administration Sets, the Royal Marsden Manual of Clinical Nursing Procedures, and the Infusion Therapy Standards of Practice. All of these explicitly state we should be flushing our intermittent infusion sets in order to deliver the full dose to our patients. Thank you for listening. That's all from me. I've got pleasure to hand over to Dr. Emma Baldock, who's going to carry on talking about this important issue.
Good morning, delighted to be here. My name's Emma Baldock. I'm a consultant microbiologist coming from Sheffield today. Some of my declarations include I'm an invited speaker by Braun, but I'm representing my own views. So I'd like to talk to you about why under-delivery of antibiotics is a problem in clinical practice. So before I get into the nitty-gritty of it, let's just think about good clinical outcomes in our patients. They're, of course, multifactorial. And we know that in the last 100 years, the biggest improvements and drivers of increased life expectancy or child and health mortality have been public health interventions. Whether that's clean water and sanitation or basic hygiene, we know that plays a huge role. Of course, vaccination is a huge part of that too, towards increased life expectancy. And antibiotics, since the first antibiotic was developed back in the 1920s, are also really important. More latterly, we've got improved nutrition, improved maternal and neonatal care, and of course, chronic disease management. So when we think about the utility of antibiotics, let's just remember that wider global context. So because we live with the luxury of antibiotics, I just wanted to take you through some basic bug-drug principles to really understand why under-delivery would be a problem for our patients in terms of their clinical outcomes. So the first concept is pharmacokinetics, or PK, which is essentially what the body does to the drug. So we take in the drug, we metabolize it, we absorb it first, we metabolize it, we eliminate it. The second concept is pharmacodynamics, or PD. This is essentially what the drug does to the body. So this might be the effects at a cellular level. How is the drug taken up into the cell? How potent or efficacious is the antibiotic? And how much do you need of it? What doses might be needed? When we think about the bacteria themselves, we think about this concept of minimum inhibitory concentration, or MIC. And that's the lowest concentration we need to give the patient in order to stop the bug growing. Now, when we're thinking about which antibiotic to treat which bug in which infection, we use these concepts of clinical breakpoints. And we have guidance on these by EUCAS, the European Committee on Antimicrobial Susceptibility Testing, and certainly we generally follow those in the UK. And ultimately, it allows us to combine the PK, the PD, the MIC data, along with laboratory and clinical evidence of efficacy, to decide on a cutoff, a threshold at which we can say, at that dose, the antibiotic will kill that bug. It is sensitive to that bug. But it might not do that. It might be a resistant bacteria. So we need to use these cutoffs. And we need to make sure we give the right dose. And again, we're guided by EUCAS on these. But if we're not giving the recommended dose, we might not get the clinical efficacy that we expect from these complex, collaborative data sets that have gone into determining that particular dose. So again, because we live with this luxury of antibiotics, we have to use them to their maximum effect. And so I just wanted to build on some of the concepts from that previous slide to talk about a particular bug-drug interaction. So I'm talking here about benzyl penicillin here and the use against Streptococcus pneumoniae, quite common bug-drug combination. And I'll take you through the graph to say that in the bottom and the x-axis, there's the minimum inhibitory concentration, which is this concept of the amount of antibiotic that is needed to kill the bug. Lower concentrations on the right and on the left, and higher concentrations on the right. And on the y-axis, we've got the percentage of the bugs that are likely to be killed. And you can see when we know the bacteria are susceptible, they're sensitive, if we give a standard dose where it says normal exposure, the vast majority of bacteria, that's a histogram of the different MICs of that bacteria, are killed. However, sometimes we know bugs need a higher exposure to that antibiotic. We need to give a bigger dose. And so it's really important we are precise with our dosing. Now, irrespective of which bug-drug combination you're talking about, there is usually an acquired or intrinsic resistant population within that bacterial species to which no matter how big a dose you give, they're not going to respond, and we call those resistant bacteria, so we have to look out for those. But my take-home message is we need to be giving the right dose if we're expecting good clinical outcomes. So the recommended doses give us reassurance that the bacteria will be killed. So my final pharmacology slide is just another common example that we use in clinical practice. You will all have heard of piperacillin tazobactam, or tazocin as we call it, and we're talking about how it might kill Pseudomonas aeruginosa, a common nosocomial healthcare-acquired pathogen that we see in patients. And you'll see the graph is very similar. So we've got the MIC, the concentration of the antibiotic needed to kill the bug on the bottom, and we've got the percentage of the organisms killed on the y-axis. Now let's say of the piperacillin component of tazocin, which is just one part of it, we give 2 grams 4 times a day. The green line shows that all the proportion of the bacterial population that will be killed by that 2 grams 4 times a day. But you'll see there's still a good number of bugs around after that, which may well cause havoc and go on and make the patient still unwell. So if we use these recommended dosing guidelines and give the correct dose of 4 grams of the piperacillin component 4 times a day, then we've shifted that green bar to the right. We're killing a lot more bugs and we're hopefully improving the outcomes for our patients. And as I said before, there's always going to be a population that is not going to be responsive to that antibiotic. They're going to be inherently resistant, and we need a different class of antibiotics for those, and no amount of dose is going to help. So my take-home message is that giving the optimal dose of the antibiotic, as recommended by these European or whichever guidelines you're following, can help us achieve good clinical outcomes, which is what we're all here for our patients. So what about in real life? How are we maximising the potential of the antibiotics that we give? You know, I look across the audience today, all you lovely people, and we're all really different, aren't we? We've got different renal function, we've got different liver function, we've got different genetic makeup, which might mean we metabolise drugs very differently. So one size does not necessarily fit all in terms of antibiotic dose. But surprisingly, we don't measure antibiotic levels in our patients all that often. When we do it, we mainly do it to make sure we're not giving the patient side effects or giving toxicity. You will have heard of common antibiotic levels being taken, such as vancomycin or gentamicin. We know both of those can be quite renotoxic or nephrotoxic, and gentamicin can certainly cause ototoxicity. So when we're measuring drugs in the patient's blood at the moment, we're essentially doing it to rule out toxicity rather than guide success. Well, why is that? Because it makes sense, doesn't it? Why shouldn't we be measuring more to know that we're going to drive success? Well, surprisingly, as you'll all be aware of, it's really logistically challenging in the NHS to do the drug levels. For example, for vancomycin, you need to take a blood level immediately before a dose, and possibly for gentamicin at a set time after a dose. So that's quite precise nursing time that is needed in that moment to achieve an accurate level. Now, there's a ward full of patients, various acuities and competing priorities. We sometimes don't achieve that. The other issue is that our laboratories are often now decoupled from our hospital. So you've then got to get this blood sample to your laboratory where it's got to be processed and analysed and resulted. And then someone at the end of that, a clinician or prescriber, has to come and change the dose to make it bespoke for that patient to say, ooh, we've not got as much in the blood as we need, let's try and increase it. And by the time you've done all that, the dosing interval may well be over. You're back to needing another dose and you might need to start again. So it's really difficult to achieve this in real time in the NHS. So often antibiotic levels in patients are fairly blind and the effect on the bug. So we often use microbiological parameters. For example, the patient had a bacteremia, they had a blood culture positive, and now they've cleared it. Or we might just have to use that the patient is better. They defervesce, their fevers come down, and their CRP, their inflammatory markers, has responded. But it's really not as technical or data-driven as it could be. So let's imagine a more ideal world where we could more regularly know how much antibiotic is in the bloodstream. We could, for example, improve those logistics. We could do more drug monitoring in the patients in real time. And we call this concept therapeutic drug monitoring, or TDM. And I mentioned that we do that regularly at the moment for vancomycin and gentamicin, but not really for many other antibiotics. So maybe that's one thing to think about. The other thing we could do is give antibiotics in a different way. So instead of just giving a single dose at the start of the dosing interval, which will get a peak concentration and then slowly drop off as the hours go by, perhaps we could give a continuous infusion or a prolonged infusion of those antibiotics that stays high throughout the whole dosing interval, so that we've got some reassurance that we're staying above that number, that minimum inhibitory concentration that we need in order to kill the antibiotics. And there's some really nice data on that now with this huge study, the BLING-3 randomized controlled trial, and subsequent meta-analyses that show that particularly on critical care patients, you can give beta-lactam infusions, tazocin, meropenem, etc., and you get better clinical outcomes. So it's all about getting the right dose in and keeping it there. And the other option, in addition to those concepts, as so eloquently explained by Claire, is that we give the full dose every single time we administer an antibiotic. And that, as Claire said, about flushing the administration set after each dose. And to me, that sounds like a complete no-brainer as a fairly ignorant medic in this concept of how it works, on the ground, on the wards. But when we survey nationally, only about 30% of hospitals are doing that. So there's some way to go there. And that's like saying, if you or I go to a GP with a chest infection and they say, great, take 2 of these tablets 3 times a day for a week, you'll feel much better. Let's say we don't do that. Let's say we take 1 tablet 3 times a day. Dropping the amount of dose by 50% of the intended dose, well, we probably won't get the same clinical outcomes. So there's these 3 concepts of improving drug delivery, but as with everything, it's tricky in real life. There's some practicalities. Some to you might seem more feasible than others, and it's something to bear thinking about. When you do understand the practicalities, the next question is, how applicable is this across our general inpatient population? We know the nursing to patient ratios on a critical care or augmented care area are going to be much higher. Can we apply what we do there across the rest of the hospital? And I know Ruth's going to talk to you a lot more about that in a moment. So for me, at least, and I hopefully convey to you that the basic scientific principles tell us that optimizing the dose of antibiotics is likely to achieve clinical success. But of course, medicine is evidence-based. So what does the literature tell us? So apologies for a slightly busy slide, but I wanted to summarize for you a deep dive that I did into the literature to support the concept of, or to understand the concept of, does under-delivery or underdosing of antibiotics lead to good clinical outcomes? So I'm going to take you through it column by column. I'm really sorry the laser point, it seems to work on the ceiling, which isn't so helpful, but you'll see for the first column to the left is the name of the first author, just in case anyone wants to look at them later, and the second column is the year the study was published. And you'll see further down at the bottom where there's more retrospective studies, they're a little bit older now, whereas some of the larger RCT ones further up are fairly recent. When we think about the type of study here, we want to have studies that minimize the risk of bias, the risk of confounding, the risk of drawing conclusions that are not actually correct. And we know that the hierarchy of evidence tells us that randomized controlled trials sit at the top of that pyramid. So when you're looking at the different types of study, yes, there's a good number of retrospective studies, which can be slightly harder to interpret because of that risk of bias. But I hope you'll agree that we've got quite a good number of RCTs there, and then the meta-analyses that come by collating those randomized controlled trials. And that brings me on to the numbers in patients involved in the study in column 4. You'll see for the RCT in the middle with the Delhunty-Bling 3 studies, over 7,000 participants in that study, which is just enormous, whereas some of the retrospective studies have far smaller numbers. But we have a really nice prospective study in the Roberts et al. 2014, where, again, you're minimizing the risk of bias because you're going forward from the intervention and looking at outcomes. When we think about what are those studies doing, well, there's a whole host of things, many of which have always to do with what I mentioned on my previous slide. Looking at individualized dosing, using this TDM, this therapeutic drug monitoring, for antibiotics that we don't normally do it for. So things like tazocin, the workhorse antibiotics that we use for sepsis and serious infections in the NHS. Some of them are looking, the second one down, at improving these PK/PD, these pharmacology concepts. Let's not just get the concentration of antibiotics above this MIC of the bug, let's get it really above and see if that improves our outcomes from sepsis. The majority of them are beta-lactams, as you'll see, most of which are penicillins, some of which are cephalosporins, but they're looking at, lots of the other studies are looking at the difference between that single intermittent dosing schedule as opposed to this prolonged or continuous infusion. Which brings me on to the final column here on the right about what outcomes were people looking at. So the retrospective studies often are looking purely at clinical outcome because that's relatively small numbers and you're looking back in time, whereas the studies further up are able to be powered to have enough participants in to look at changes in mortality and also clinical outcome, clinical cure rates. And hopefully you'll agree with me that the majority of this slide is green. Well, what does the green mean? So I've highlighted the studies in green that show a favourable outcome to telling us that optimizing the dosing improves clinical outcomes. So if we get the right dose, we give the full dose, and we get it in and we keep the dose high, then we tend to see better outcomes in our patients. The orange show a trend or a positive signal towards improved outcomes with optimized dosing, but weren't statistically significant, and the grey had no difference between those two options. But hopefully you'll agree with me that under-delivery and under-dosing of antibiotics is not in the best interest of our patients. So my penultimate slide now is just to highlight one final of the negative consequence of not giving the right antibiotic dose, and I'm going to talk through that with this slide, with this graph. So you'll see I've got a graph here of time along the x-axis, and we've got log CFU, which is essentially the colony-forming units, or the number of bugs that we have in a particular infection. And if you see the yellow line, this is our sensitive bacteria. If you think about the graphs a couple of slides ago. So these bugs that should be well killed by these antibiotics. And the yellow line shows if you start with your antibiotic and it's effective, you should nicely see this yellow line going all the way down to the baseline. Most bacterial populations will already have a resistant population, which will just be hanging around, whether that's acquired or intrinsic resistance, and that will be slowly, steadily increasing when they've got less competition from the sensitive bugs. But let's imagine a world where we're not giving the right dose of that antibiotic. Perhaps less of our sensitive population are killed. Perhaps we're then giving them a selective advantage that they need to acquire a resistance gene or a plasmid from their little resistant neighbours next door. And so we're increasing the number potentially of antimicrobial resistant bugs. And we all know that that is a global health threat and something we really need to be on top of in the years to come if we want to still be treating common infections. So in summary, the right amount of antibiotics that we give a patient is absolutely paramount to ensuring a good clinical outcome. There are several ways that we can improve the amount of antibiotics and optimize the doses we give to our patients, and I've shown you a couple of examples today, and maybe just have a think about which ones feel more achievable and how we might optimize and improve this delivery in the future. But ultimately, successfully treating infections is what we're here to do. We're trying to reduce antimicrobial resistance along the way, because we obviously want for ourselves what we would want for our patients, which is good clinical outcomes.
So thank you for inviting me to speak today, and I'm delighted to be able to share my experiences of implementing the practice of line flushing to eliminate underdosing of IV antibiotic therapies. Being responsible for the critical care service at BHRUT placed me in an ideal position for implementing a change to our practice. It is a large service comprising of 57 beds across 2 sites, including a specialist neurocritical care unit. Like all intensive care services today, it is busy, with high occupancy rates and high patient acuity. Here we manage the sickest patients in the hospital, see a high number of sepsis from both community and hospital-acquired infections, resulting in patients requiring multiple intravenous antibiotic infusions. So what motivated me to implement line flushing in the service? It was a simple need to get things right for our patients. Once I had an awareness of the gap in care and the implications, it was essential for me to rectify this. Patient safety is at the forefront of our care, and anything that compromises this must be addressed. Inadequate early treatment of sepsis can result in the onset of multi-organ failure, increasing the risk of mortality in something that is treatable. 5 people die from sepsis every hour in the UK. We have the Sepsis 6 management tool, with one key element being the delivery of IV antibiotics. If underdosing occurs at this point due to lack of line flushing, there is a risk of harm from deterioration. As previously mentioned, antimicrobial resistance is a real threat to healthcare globally. The UK government, in their 20-year vision for AMR, have outlined its commitment to contain and control antimicrobial resistance through strong mitigation by lowering the burden of infection, optimal use of antibiotics, and a full antimicrobial resistant research and development programme for antimicrobial alternatives, diagnostics, vaccines, and infection prevention. Given this, the contribution of underdosing and incorrect disposal of antibiotics, National Health Service organisations have a responsibility to address what they can, as soon as they can, to support this. The cumulative effects of underdelivery of antibiotics means that over time, patients end up missing out on significant amounts of their prescribed treatments. Inevitably, this will lead to delayed recovery and extend patients' length of stay, not only in critical care, but also in hospital. We were all aware of the high demands on hospital beds, with the safety implications of not being able to adequately deliver care at the point of need. All measures need to be taken to minimise the need for hospitalisation through rapid treatment and early recovery. Implementing the line flushing in critical care was approached via a number of steps. Firstly, we needed to decide on which method would be the optimal one for patients, staff, and also procurement, with consideration of costs to be factored in. It was decided that to procure the safe set flush would be the best solution in supporting our ability to adopt this important change in practice and allow us to deliver antibiotics in line with nationally recommended guidelines. Reasons that we regarded the safe set flush as the desired option was threefold. It minimised the number of disconnections of lines, would be more time efficient for nurses to use, and reduce the risk of fluid overload with the volume of fluid limited to the amount required. In looking at the process of IV medication administration in our units, it was interesting to analyse this in detail, as it came to light that for every medication given, a new line was used. It had not been flushed, so it was changed each time. It was an additional bonus for the service that adopting the practice would likely see a reduction in sets used, plastic waste, and potential cost savings, significant additional benefits on top of the patient safety and antimicrobial improvements we were setting out to achieve. The next steps towards implementation was to ensure buy-in from all the relevant key stakeholders. This included the critical care medical and nursing teams, the trust procurement team, pharmacy, microbiology, and IPC. On presenting the issue of under-delivery of antibiotics and the implications of this to my colleagues was met with a great deal of support. There was an element of, how did we miss this? Procurement teams were also very understanding of the need, and being able to evidence the patient safety and antimicrobial resistant improvements, as well as an anticipation reduction in sets used, helped with their buy-in, as we could show how the additional cost of the sets would easily be offset. Whilst procurement could sometimes be sceptical when clinicians are requesting approval for different consumables, they are also understanding of the need to strive for improved patient care, with clear and measured rationale of the need and benefits helps to get them on board. And here, whilst I had little data to demonstrate my ask, the logic behind the practice was evidence enough. We finally launched the new practice in January 2023, and with support from the Braun medical clinical specialist teams, training was provided to the nurses. As I started looking into improving our practice in IV antibiotics administration, it highlighted the ways of working across the units. Multiple numbers of lines were used per patient per day. With a safe set flush, which could remain connected when flushed and used for subsequent doses, we were looking at a significant reduction in sets used. A specific line label was also produced to support the practice of line labelling. As we are striving to adopt more sustainable ways of working, this has proved an added benefit for us. It has also led me to link in with the Trust and North East London sustainability networks, partnering together to increase the reduction in plastics and consumable waste across the network. Reduction in the number of administration sets used with the implementation of the practice has been as anticipated. Initial comparisons using 2021 pre-COVID data, in our first year we saw a reduction in use by around 1,300 per month. This was very encouraging, especially as it covers the time period when the process was new and not fully embedded. We have continued to see a reduction in sets used and achieved a 62% overall reduction in single-use plastic across the service. This created a cost saving of £4,000 for the service and is an important consideration for building a business case to obtain finance and procurement approval for obtaining the safe set flush lines, where concerns may be raised that this creates a cost pressure. We evidence that this was not the case. With the support of the pharmacy team and Braun, we looked at our antibiotic usage in the months of December 2022, pre-introduction of antibiotic line flushing, and December 2023, 11 months post-launch of the new practice. Looking at the 5 most commonly used antibiotics, we observed a reduction in usage in all 5 groups, totaling 21% fewer antibiotics delivered when adjusted for patient occupancy. Utilising the findings of the NHS Greater Glasgow and Clyde and the Centre for Sustainable Healthcare, who suggest 1 episode of an IV administration has a carbon footprint of 1.6235 kilograms of carbon dioxide equivalent, the 21% reduction observed equates to 46 return flights from the UK to Spain. Recognising that care to our patients needs to be equitable, regardless of location in the hospital, full dose administration needed to be adopted trust-wide, and I set about implementing line flushing practices across all areas, delivering intermittent intravenous medications. Replicating the steps I took for implementing the practice in critical care, I linked in with the nursing and medical teams in the clinical care groups, as well as reviewing the need for a trust-wide implementation with the key stakeholders as before. The SOP was reviewed and amended to align with care delivery in the ward areas and how the line flushing needs to be managed in ambulatory patients. Usual practice on the ward is to disconnect the administration set once the infusion is completed. Obviously, once disconnected, it had to be discarded. So the reduction in numbers of sets used is not as anticipated to be as we have seen in critical care. However, in examining current practice with the absence of line flushing, additional sets are used for additional antibiotics for the same patient. So with the implementation of line flushing, we would hope to see some reduction in use. Key points to training for the process has been the adherence to best ANTT practices when accessing the needle-free connectors and to always administer the flush at the same rate as the antibiotic dose. As with any change in practice, there are challenges and obstacles. It's not been easy, and we are not quite there yet. The main issues we have encountering during the trust-wide rollout has been getting consistency in the practice change in all ward areas and supply issues due to varying demands in areas. Communications in team huddles and quality meetings with continued support in all clinical areas with the Braun team, as well as the Trust PDN and IPC specialist, a coordinated and collaborative approach was provided to ensure that the full dose administration of IME medications is ingrained in our normal practices. As previously mentioned, ward practices differ from critical care in that disconnection is more frequent with patients being ambulatory, and once disconnected, the sets need to be discarded. However, with the previous practice of using different sets for different medications, flushing has brought about the ability to reuse the lines when able, and we have observed a 29% decrease across the trust in the first 6 months post-implementation. The NHS uses approximately 30 million administration sets a year. So if what we are seeing at BHRUT can be replicated through this change in practice across the NHS, the anticipated benefits could reduce this by nearly a third, equating to around 290 tonnes of plastic waste reduction, the equivalent weight of 24 double-decker buses. Although it is important to remember that not only the scaling up of sustainabilities will be released, the benefits of reducing under-delivery antibiotics will also be actualised. So where are we now? A recent audit carried out in February this year has shown ward compliance rates with line flushing to be 78%. So there is still ongoing education and training required. Practice observed during the audit also demonstrated that additional sets were used when only one was required, which, when rectified, will help to reduce numbers of sets further. As for the next steps, while the logic of the need to do this is a no-brainer, we are starting to put together a research proposal to extrapolate data looking at a number of metrics and outcome measures that will demonstrate the benefits to provide additional support for this essential practice change. In summary, the flushing of intravenous lines following infusion of prescribed medication needs to be reinstated as routine practice. Patient safety sits at the heart of this and is the foremost important reason that this needs to be done. Recommendations from the report following the Freedom of Information inquiry launched in November 2023 is that this needs to be adopted nationally and monitored by regulators. Antimicrobial resistance is an existing and real threat. Action is needed now to ensure that we have some weapons remaining in our arsenal for future generations. In times of increasing financial pressures, any element of improving healthcare efficiencies and reduction of unnecessary use of consumables needs to be embraced, along with the sustainability benefits for the greener approach to our healthcare delivery. I love this quote from Florence Nightingale, who said, "For us who nurse, our nursing is a thing which, unless in it we are making progress every year, every month, every week, take my word for it, we are going back." It is quite incredulous, her foresight on the need for innovation in the very early stages of nursing. Whilst the advancement of infusion pumps with their safety features and their time-saving qualities meant line flushing became a lost practice and under-delivery of full dose of antibiotics occurred, we need to continue to progress our practice to make sure we don't go back, but maintain advances in our healthcare delivery and sustained innovation, both of which underpin our ability to provide safe and effective care to produce the best patient outcomes, combat antimicrobial resistance processes, reduce drug-resistant infections, whilst driving down unnecessary costs. So at the end of the day, it is a simple thing to be doing. Flush the line every time for sustainable IV antibiotic administration and total dose delivery. Thank you.